Hello, good afternoon, everyone. Very nice to see you all. My name is Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. And we are very happy to welcome you to session number 8 for our clinical education webinar series, which we are holding in partnership with our sister organization, Riverside County Medical Association, as well as Inland Empire Health Plan, who has provided support for this series. Today's session is entitled Arthritis, Osteoporosis, and Joint Pain from Challenge to Solution. And our speaker is Alex McDonald, MD, CAQSM, and FAAFP, who is a family physician, sports medicine physician at Southern California Permanente Medical Group, Kaiser Permanente. And as you all know, this series is a sequence of 12 sessions designed to help primary care providers and their staffs navigate the world of diagnosing various conditions and deciding when and how to refer those conditions and treatments to specialists, because oftentimes that's the missing link. So that's a very important part of the process that we want to help you with. And Dr. McDonald is going to help you travel through that journey today. So I'm going to introduce Dr. McDonald very officially now so that we can celebrate him. Dr. McDonald is our incoming president-elect for the San Bernardino County Medical Society, but that is just the tip of the iceberg for his many accomplishments. He is an educator and thought leader in the fields of physical activity, lifestyle medicine, preventive medicine, and health policy. He is a partner physician at Southern California Permanente Medical Group in Fontana, California, where he is a core faculty member and clinical professor at the Kaiser Permanente School of Medicine, Family Medicine Residency, and Sports Medicine Fellowship. Dr. McDonald, as noted, is on the leadership board for the San Bernardino County Medical Society and our president-elect. So we're very excited about that. He will take office as our president next July 1st, 2026. So he's currently on our executive committee. He is also the past president of the California Academy of Family Physicians, and he is a trustee with the California Medical Association. Dr. McDonald also served on the American Academy of Family Physicians as chair of the Commissions on Membership and Membership Services, as well as on the Congress of Delegates. Dr. McDonald holds a BA from Connecticut College, as well as his medical degree from the University of Vermont Larner College of Medicine. He completed his medical internship at Duke University and his family medicine residency and sports medicine fellowship at SoCal Kaiser Permanente. Dr. McDonald lives with his wife, Dr. Zucker, an adult child and adolescent psychiatrist, 3 amazing children who attend Claremont Unified Schools, and their 3 dogs. He enjoys running, riding his bike, cooking, coffee, and 8 p.m. dance parties with his kids. And I'm going to add, he also is the master at selfies, and we rely on him for that often through our organization. So, Dr. McDonald, we welcome you, and thank you for joining us today.
Thanks so much for having me. I really appreciate it. I hope this is useful for everyone. I'm really excited to be able to present this information. I get very excited. I talk very quickly. I apologize in advance, and so just drop your questions in the chat if things go fast. There are some audience participation questions, and so make sure you answer those in the chat as well. I'll give you all a minute or two to jump in there, and let me jump in here and share my screen. Let me do this, and we'll share. All right, can you see my screen? Is it like full screen mode?
Yes.
All right, perfect. Okay, so we're going to talk about, as Allison said in her very nice introduction, arthritis, osteoporosis, and joint pain. And there is lots of challenges, and unfortunately not a ton of solutions, but there are certainly some solutions, and we want to just kind of go through the events for all this. So first of all, there we go. Again, I have no disclosures for this. However, I am not a surgeon. I don't like surgery, and I use surgery as a last resort. I tell my patients, your chance of having surgery goes up significantly if you see a surgeon, and so I often try to help them as best I can without referral, but when necessary, obviously it's appropriate. So Allison already gave my introduction, so you kind of know who I am and what I'm about. So we're going to talk here, just kind of quick summary. We're going to talk about osteoporosis first, and then joint pain, and then more specifically arthritis. We're going to talk about some other causes of arthritis, and then we're going to talk about low back pain because that's a real kind of sticky wicket, if you will, in a very specific high yield application in the primary care clinic or just pretty much anywhere. You go to a dinner party, I guarantee you someone there is going to have some back pain. So this is kind of the overview of where we're going to go today. Really, by the end of this, I want people to be able to sort of understand the clinical impact of osteoporosis, arthritis, and back pain, really know what is the evidence and how do we apply those evidence-based strategies for not only diagnosis, but also risk assessment, screening, clinical treatment criteria, and also just some red flags that make us think, okay, we need to get this more workup or get this patient to a higher level of care rather than just the primary care office. And then lastly, we're going to be talking about approaches for non-pharmacologic and as well as pharmacologic and then procedural therapies for all these issues. And then lastly, really understand the impact of these conditions on daily living, physical performance, quality of life, and the impact on the healthcare setting overall. So here we start with osteoporosis, right? So osteoporosis, as many of you know, is just thinning of the bone essentially, a larger, more air, less trabecular bone, higher risk of fracture, obviously, and less stability. So, all right, audience participation. Put your questions here in the chat. So, what percentage of patients have osteoporosis and don't know it? I'll give you guys a second to put it in here. See how many of you are paying attention. 25%. 10%. And the other guess is 50%, 40%. Okay, all right. So really, osteoporosis is highly prevalent, especially in older adults. It often leads to significant morbidity and mortality, increased fracture risk. It really affects about 10 to 20% of adults over the age of 50. So it's really pretty significant. However, this is the kind of the crazy number when I was preparing for this presentation. A substantial percentage of patients, about 70% of patients have osteoporosis and don't know it, which is kind of crazy. And they're really unaware. They either have not been screened appropriately, or they have risk factors, but then no one's ever sort of put their risk factors through the FAAFP calculator to determine, okay, what are next steps. So this is as we again, very high prevalent in society for older adults and very, very underdiagnosed and undertreated, which can really significantly cause a lot of morbidity and mortality, as we all know. So here's the key, really. We think about diagnosis of osteoporosis primarily on the T-score. So this is one of the main ways. And so a T-score after a DEXA scan of less than 2.5, excuse me, less than negative 2.5, or the presence of a fragility fracture is all you need for diagnosing osteoporosis. That's the key. You can have a fragility fracture and diagnose osteoporosis without a DEXA scan. Obviously, we want to get a DEXA scan. We want more objective information. And really, timely screening and that risk assessment with a FAAFP score is most appropriate. And then determining, okay, what's the next treatment? What are the follow-up? How do we make sure patients are adhering? So again, here the T-score values, greater than 1 is great. -1 to 1 is normal. -1 to -2.5 is osteopenia, which is not a real thing. I mean, it's a thing, but like I don't know, it's like pre-osteoporosis, and like what does that mean? I don't know what that means. And then less than -2.5, that's really osteoporosis, and that's where we have to be thinking about our treatment and options here. So what is the FAAFP? We all remember the FAAFP calculator, hopefully. For those of you who are not aware, so FAAFP incorporates someone's age, their sex, their body mass index, prior fracture, history of hip fractures, if they're a smoker, their alcohol intake, if they're on chronic glucocorticoids, if they have rheumatoid arthritis, if they have secondary osteoporosis, and then optional bone marrow density. So really, that's the FAAFP score. It's validated between 40 and 90 years of age. So it's a very wide range. And so anyone who's over 40, we can actually use a FAAFP to determine if they're higher risk. So really, the universal screening, though, is a little bit different than just that. So screening is anyone over any woman at age 65 should be screened at least once. We know women have higher risk of osteoporosis, and every woman at age 65 should be screened at least once. Now, younger women, postmenopausal women with risk factors, we may want to screen them. Men over 70 who have risk factors should also be considered for screening, although not as strong recommendation there. And then lastly, any history of a fragility fracture, like I said. So a fragility fracture is basically any fracture that occurs from a low energy trauma, such as a fall from a standing height or less, or just kind of minimal, something you wouldn't really expect a bone to break. Anyone who breaks a bone falling from a standing height should be screened for osteoporosis. And again, if you're worried, you can actually just diagnose it just on that. However, getting a DEXA scan for more objective measurement certainly makes a lot of sense for these patients. And so I see someone put the FRAX score calculator in there with MedCalc. Here it is. You can Google this. You can go to MedCalc. The FRAX calculators are everywhere, and they're usually free. So you just put in age, birth date, sex, weight, blah blah blah. Kind of go through this, yes, no, and it'll basically tell you what their risk is, and often will recommend bone marrow density, DEXA scans, or whatnot. So here's another way to think about osteoporosis, right? So always starting with a good history and physical exam, right? Remember that? A lot of the medical students and residents I teach today just talk about labs and imaging, and they forget about the fact that a history and physical exam is paramount to good high quality medical care. So starting there. Now, if they have a history of a fragility fracture, or they have a fragility fracture which is present, again, you can just diagnose them with osteoporosis. Obviously, getting a DEXA after that is helpful. But once they have a fragility fracture, boom, they have a diagnosis. Now, here's the next one: patients with vertebral compression fractures. So this is a little bit kind of a subset, if you will. If they have a vertebral compression fracture, if they have a loss of height of greater than 1.5 inches, if they have severe kyphosis, chronic steroid uses, then often we'll image the spine just with traditional X-ray, and then based on that, kind of moving down the pathway farther. And this next group over here, the 65-year-old females, everyone should be screened with a DEXA at least once, and then based on their score, if it's less than -2.5, boom, osteoporosis. If it's sort of in that osteopenia range, then often just kind of monitoring, doing a FRAX score, and then kind of following up based on clinical signs and symptoms. And then obviously, if they have a normal bone marrow density, oops, I went too far. If they have a normal bone marrow density, then there's nothing to worry about at that point. You just reassess at an appropriate interval from there. So that's kind of those of you that like the flow sheet of how you think about osteoporosis, and those are kind of those big buckets. But really creating a systematized process which helps us screen patients. We have a million things to do. There's a million USPSTF preventative task force recommendations, and really creating systems and relying on your team is really critical when it comes to making sure patients are getting screened appropriately and follow up as well. So how do we treat this then? Really, there's sort of non-pharmacologic measures. Calcium and vitamin D supplementation is really the mainstay here. Weight-bearing exercise. This is, again, I'm a sports medicine, lifestyle medicine guy, and I always talk about physical activity and exercise and lifting weights, and cycling is okay, but walking, running, strength training, those are really the important, where you're adding more you're putting stimulus on those bones to help create stronger muscles, stronger bones. And then lastly, this third piece here, which I think a lot of people forget, is fall prevention. Balance exercises, balance training, keeping those muscles strong is really going to prevent falls. And if we know somebody already has thin bones, osteopenia or osteoporosis, if we can prevent them from falling, then that's obviously the key. So balance and fall prevention is really important. First line here is pharmacologic therapies. It includes the oral bisphosphonates. And then there are some other monoclonal antibodies for high risk patients. And then there are some anabolic agents. I'm not even going to try to pronounce these names, but those are usually for very high risk individuals. And I almost always refer those to endocrinology. I really, for me in my practice, oral bisphosphonates are really kind of where I start. And then with all these lifestyle interventions and non-pharmacologic measures is really key. So, I just kind of said this there. Oh, I forgot about this one. IV zoledronate is an IV bisphosphonate, which is just once a year, which is a little bit more convenient. Patients don't have to worry about taking a pill every week. With the oral bisphosphonates, there's less risk of esophagitis and other kind of positional issues which patients have with the bisphosphonates. And then lastly, this one other category here is the selective estrogen receptor modulators or hormone replacement therapy for specific populations such as younger postmenopausal women, those at high risk of breast cancer. Doing hormone replacement therapy or a selective estrogen receptor modulator may be reasonable to help increase bone mass, bone strengthening, and reduce the risk of fragility fractures. This is a clinical, really a clinical and shared decision making with your patient based on their individual risk factors and their situation overall. Really, when patients have osteoporosis, again, the medications, the mainstay are the bisphosphonates. The common side effects, as I mentioned, are, oh, I'm sorry, I'm getting too many notifications here. The common side effects are really esophagitis and gastritis, which is why you need to take it in the morning, standing for at least 30 minutes. Some patients get sort of an acute phase reaction. They get fevers, chills, myalgias, things like that. Yeah, that's pretty rare. The esophagitis is more common. Very rare is the osteonecrosis of the jaw, which is why every single time I get a dental clearance from any dentist anywhere, they ask if the patient's on a bisphosphonate. This is really 1 to 6900,000 person years, so it's really pretty rare. And then lastly, atypical femur fractures, again, between 0 and 90 per 100,000 person years. And this is particularly higher risk for the intravenous bisphosphonates. Older women, women of Asian heritage are higher risk for these atypical femur fractures. And essentially what happens is you build bigger bones and stronger bones, but those bones are a little bit more brittle. So this is, again, something you have to think about, but again, pretty rare and low risk, and everything has to be taken in that risk-benefit ratio. Really, once you know someone has osteoporosis, you start them on treatment. Should repeat a DEXA scan in 2 years just to sort of see where their T-score goes. And then it's important to think about a bisphosphonate drug holiday every 5 years. Some patients just get put on these medications and just the refills just kind of keep rolling. You get a refill request and you refill it, and you get a refill request and you refill it. It's important to reduce the risks of osteonecrosis of the jaw and atypical femur fractures to take a drug holiday about every 5 years or so while patients are on a bisphosphonate, and that can reduce the risk of some of these side effects. It's been shown that even after a year or even 2 years of stopping the bisphosphonate, they still have some increased osteoblast activity and bone strengthening afterwards. So really the goal here, thinking about medications, thinking about lifestyle, and then thinking about monitoring. Those are kind of the 3 ways we kind of think about ongoing treatment for osteoporosis. It's not about one or the other. I always tell patients, if you sort of maximize the lifestyle pieces with weight-bearing exercises, strength training, fall prevention, we can maximize the medication side effects, or even we can minimize the need for medications, and then keeping ongoing monitoring and thinking about the FRAX risk assessment, which things can change over time. And so just because you do the FRAX once doesn't mean you don't ever have to do it again, because things change as we all know. All right. And that was osteoporosis in like 5 seconds. And so I told you I'd talk fast and get excited. Let's move along to the ever ubiquitous joint pain topic here. When Allison asked me to present this, and I said joint pain, that's going to take me like 3 days to present all the different types of joint pain. So we're gonna kind of hit the highlights here. So hopefully this is useful for everyone. Again, 30 at any given point. Right now, sitting here on this webinar, between 30 and 50% of all adults are experiencing joint pain, right? It's extremely common. It's one of the most common chief concerns patients present to the doctors. It's estimated about 30% of primary care visits are for some kind of musculoskeletal issue and joint pain, and it has an extremely broad differential. And so when I see joint pain walking in my office, I get a little bit excited, because obviously I like joints and I like sports medicine. One of my colleagues, anytime she hears any kind of musculoskeletal complaint, she runs screaming the other way. But it's something we all need to do, especially those of us in primary care. So there are a ton of causes of joint pain. The main one here is osteoarthritis. That's probably the most ubiquitous, which we're going to talk about here in a little bit more detail, followed by overuse injuries, ligament injuries, tendonitis, bursitis. Those are usually more common in younger, physically active adults. There are the crystal arthropathies, gout, pseudo-gout. These are more common in sort of mid adults. Usually they have sudden, severe, atraumatic onset. It's most common in the first metatarsal joint, or podagra for the toe, the wrist, and the knee. Those are the three most common joints, but they can affect any joint anytime. Estimated about 4 to 5% of joint pain is crystal arthropathies. Rheumatoid arthritis. This is pretty rare, only about 0.25% of all adults. This is obviously polyarticular. It just usually has prolonged morning stiffness. There's obviously some synovitis. You can feel some bogginess of the joints. You can think about lupus or psoriatic arthritis, all in this family of sort of rheumatologic conditions for arthropathies and arthritis. Lastly, trauma. This one's usually pretty straightforward. Like someone felt fine until they fell, and then their joint is painful and swollen. That one's usually the diagnostic dilemma there is not too broad. And then lastly, septic arthritis, which is actually really pretty rare, but obviously a medical emergency and needs to get that patient to the ER or the OR pretty quickly if it's a true septic arthritis, especially if they have foreign bodies, if they have joint replacements. We obviously worry about that quite a bit. But again, extremely rare. The top two probably make up the vast majority of what we're going to see, followed by certainly the top three probably make up the vast majority, followed by the less common things down below. All right, let's talk about arthritis, because arthritis. MT. First, the first metatarsal joint, the base of the great toe. That's what MT stands for. Sorry about that. Arthritis. So this is what we're going to talk about here. Even of itself, arthritis has hundreds of conditions. It's really the leading cause of disability in the United States, and osteoarthritis, or as I like to refer to it, as the accumulation of life on your joints and your bones, is the most common. Again, followed by rheumatoid, psoriatic, and other types of arthritis. So osteoarthritis. Really, this affects between 53 to 67 million adults, or about 25% of the adult population. Obviously, this increases sharply with age. About 14% of all adults age 25 and older, and 34% of adults 65 and older have osteoarthritis. It starts pretty young, actually, which is, I think, is the surprising thing, is you can have post-traumatic arthritis as early as your 20s in a lot of individuals. Osteoarthritis prevalence has more than doubled from 1999 to 2014, and so people are, how should I put this? The population as itself is more sedentary. There's more risks of obesity and being overweight, which obviously puts more pressure and chronic wear and tear of those joints, and it increases the risk of osteoarthritis pretty significantly. Knee and hip are the most common joints affected, but obviously it can affect any joint anywhere. And it's important to note that there are certainly racial disparities exist. Osteoarthritis is much more common in Black adults compared to white adults, and actually has higher rates in women overall, for reasons which are not exactly clear. Again, leading cause of disability in the U.S. The direct and the indirect costs of osteoarthritis really exceed $300 billion, 185 billion in direct medical costs per year, 65 billion in lost wages annually for patients who miss work because of their osteoarthritis. A lot of patients who are more blue collar workers who do more physical manual work often are limited more because of the inability to physically do their job when they have significant osteoarthritis. It's estimated actually by 2040, the number of adults with arthritis is projected to increase by nearly 50% to 78 million. And those experiencing this activity limitations will rise as well to 35 million. So it's a problem which is here, and it's getting worse, and it's going to continue to get worse. Maybe with the GLP receptor agonist, maybe we'll reverse this trend. I don't know. Did anyone else see that study that the rates of obesity actually fell for the first time in 50 years? I think this past year, and largely attributed to GLP-1 receptor agonists. I digress.
My God.
So osteoarthritis. Really, this is a clinical diagnosis, activity-related joint pain, brief morning stiffness, usually less than 30 minutes, and then some functional limitations. Often there's crepitus, there's some bony enlargement on exam. They may have a restricted range of motion, are all very highly specific for osteoarthritis. And imaging is not necessary. Do you guys know this? You don't need X-ray to diagnose osteoarthritis. It is a clinical diagnosis. That being said, imaging is usually helpful to determine if there's another diagnosis, if there's a little bit of uncertainty in the diagnosis, and also to grade the degree of osteoarthritis. And so again, X-ray really confirms the diagnosis and assesses the severity. How much joint space narrowing do you see on X-ray? How do you see osteophytes, subchondral sclerosis, or cyst formation? And here's the thing also, I always tell patients is the patient's symptoms don't always correlate with imaging. Normally, I have a patient who has like an okay looking X-ray, but they have horrible pain and disability. And I have some patients whose X-ray shows complete bone on bone, and they're like, yeah, it hurts, but it's fine. And so really the imaging and the patient's clinical symptoms don't always correlate, and really focusing obviously, being patient-centered in our approach and thinking about the clinical symptoms is really the most important consideration here when we're thinking about treatment options and how severe the arthritis is. This is an interesting guideline. 2022 NICE guidelines really supports a clinical diagnosis in patients aged over 45 years with activity-related pain and and brief morning stiffness and without the routine use of imaging. And so I think we all kind of are used to this, but it's really not necessary to get X-rays to diagnose osteoarthritis based on clinical history and exam. Right? Remember, physical history and exam is going to help get you diagnosis 90+% of the time, and I think this is a great example of that. Here's just a chart kind of talking about the different sensitivity and specificity as well as the likelihood ratio with these different pieces. So again, if you see bony enlargement, if there's crepitus, if there's osteophytes on X-ray, if they have knee pain plus osteophytes, that's pretty highly correlated of knee arthritis. And then hip internal rotation less than 15 degrees, pain with internal rotation, decreased hip adduction, again, bringing it closer to the body. If they have femoral acetabular osteophytes on X-ray, if they have some narrowing of the joint space, and then if you see some osteophytes. And so these are all clinical or radiologic findings, which can basically, give you your diagnosis with a very high likelihood ratio. So again, when we think about osteoarthritis, if we are going to talk about imaging, MRI is really the most sensitive. Radiographs are kind of the standard for clinical assessment. Again, not required. CTs typically are not utilized for a diagnosis of arthritis. Sometimes they'll get a CT for something else, and they'll happen to find arthritis. A lot of times you get a CT abdomen pelvis, and they say, oh yeah, there's some arthritis on the hip joints. So you can use it, but it's not usually what we'd go to first. Again, here's just for those of you who like pictures. Here's some imaging of the X-rays above, which shows some, pretty severe arthritis. Very narrowing of that medial joint line there with that red, pink, purple. I don't know what color is that? What red arrow? We'll call it a red arrow. And then the blue arrows show a little osteophyte formation, which are very common. Medial joint line is the vast medial joint line of the knee is the most common arthritis that we'll see in most of our patients. And then for MRI, often we'll see these sort of subchondral cysts formation. You can see with those little yellow arrows there. You can see some bone marrow edema. You may see fluid like that black arrow. You see some hyperechoic or white fluid here in the superior patellar space, and then you may see some tears or wear and tear of the meniscus, like we see here in that blue arrow, in that joint space posteriorly on that knee MRI. You don't need an knee MRI. A lot of people get knee MRIs, and then it just creates more confusion, honestly. And I'll talk about that here in just a minute. So okay, next audience participation question. Okay. Everyone open the chat. Get ready. What is the difference between osteoarthritis and a degenerative meniscus tear? I'll give you a minute to answer, and I'll take a drink of water. All right. Arthritis is the joint space alone. Meniscus tear involves musculature. Arthritis is chronic. Bone versus cartilage. All right. These are all good answers. Anyone else? I'm glad at least three of you are paying attention. It makes me happy. I'm not just talking to myself. Anyone else? Arthritis can be present inside a tear. I like it. All right. So I actually think of this as a spectrum. So really, in the early stage, you can get a meniscus tear. This is often traumatic. It's often in younger individuals. And we think about a sort of a meniscus tear, if you will. In sort of that mid stage, you sort of have mild arthritis. You have some joint space narrowing. And if you already see joint space narrowing on X-ray, I can tell you without getting an MRI, there's already likely some degree of degenerative meniscus damage and potentially tear. And then when you have severe arthritis, I mean, there's no cartilage left, there's no meniscus left, there's nothing left. You're just sort of bone on bone to some degree. And so I think about a meniscus tear and osteoarthritis actually on a spectrum. A lot of times when patients have a meniscus injury as a younger individual, they increase their risks of developing arthritis significantly. Now, if they go in there and remove part of that meniscus tear, they can actually increase their risk of arthritis even more. So anytime we have a meniscus tear in a young individual, or even a middle-aged individual, I try not to do surgery or recommend surgery for those patients. I try to rehab those, work on weight loss, work on strengthening to stabilize that joint. And oftentimes that may be enough to minimize symptoms and get them feeling better, because we can go in there and we can kind of clean up the meniscus and get them feeling better faster. However, it increases the risk of developing arthritis, 3 to 4 fold within 10 years. And so that's really the key here is someone in their 40s, I can tell them they probably have some mild arthritis on X-ray, and they probably have some mild meniscus degeneration on an MRI. And so I try to convince my patient. I almost never order MRIs on patients over the age of 45, because what happens is it just confuses people and they say, "Oh, I have a meniscus tear, I need surgery." And I honestly, I don't think that's necessarily the best thing for patients long term. And so this is kind of a
Yeah,
nuanced
not
point,
too
which I'm
long, no.
constantly harassing my residents about to understand that difference and thinking about a meniscus tear and osteoarthritis on a spectrum, because it's really kind of it's really a spectrum of the same disease essentially. And one is just later stages, one is just earlier stages, which is a lot of times why when you have a post-traumatic injury, patients in their teenage who have a trauma, who tear their ACL, almost all of them develop arthritis within 10 years just because of the injury, regardless of how it's treated moving forwards. So, all right. Okay, moving on. So how do we treat this? Again, like I said before, I'm a lifestyle medicine guy. We always start with non-pharmacologic treatment. So regular exercise, weight loss, self-efficacy programs are really the critical piece here. Physical therapy, the use of assist devices, a cane, a knee brace, some kind of orthosis, strengthening above and below the affected joint, I think is really important also. And then also, oh, my light turned off on me. I'm sitting in the dark. Cognitive behavioral therapy. Obviously, patients, this is significantly impacts patients' quality of life. Most patients who have chronic pain from anything, regardless of whether it's osteoarthritis or otherwise, have some, mental health impacts, some degree of depression or anxiety, just because they can't do the things they want to do, or they have constant pain. And so, making sure we get patients, we think about the physical as well as the cognitive and behavioral therapy components of this is really, really important. I have a lot of, middle-aged runners and physically active people who have mild arthritis, and if we get them onto a good strengthening plan, they can often do okay. Is it 100%? No, but we can get them functional to the things, to the point where they want to do the things, they can do the things they want to do, and I think that's really, really the key. Okay, so let me talk about pharmacologic treatments, right? So we can talk about topical or oral NSAIDs. This is really sort of the mainstay when it comes to reducing pain and inflammation. Patients will often have pain and they take, a Motrin or naproxen, and that's great, but they only do it once or twice. And I tell patients, especially if you're having a flare of your osteoarthritis, taking NSAIDs, 2, 3 times a day for several days in a row can help reduce inflammation as well as treat the pain. So it's a combination depending on how bad your pain is, how much of a flare, how frequently. you can use NSAIDs, for most people, as long as they're taking them with food and water, as if their kidneys are healthy, usually not too much of an issue. I discourage people from taking them chronically for more than a week or two at a time. But obviously, it's an individual call based on that. The next treatment here, obviously, is intra-articular corticosteroid injections, right? Why would we take a pill and have sort of systemic effects when we can kind of go right to the source and put corticosteroid directly into the joint? This is sort of the main stage. This is what I do, for most of my patients who are to that point where their pain is so debilitating they really can't do the things they want to do, or patients who have arthritis and they can't do their rehab because of the pain. That's really with the time to use corticosteroids. Um, Duloxetine, SNRIs, are often considered that can help with both the mood as well as the norepinephrine component of pain. Acetaminophen, tramadol, topical capsaicin can be help. Opioids really should be avoided. There's pretty clear guidelines here. Opioids can help, but should really only be reserved for the most severe cases or patients who are refractory to other treatment options because of all the negative downstream side effects. Lastly, and this is sort of the biggest thing in the news recently, is platelet-rich plasma, or PRP injections in arthritis. Particularly knee arthritis is really pretty mixed. For some reason, in the past year, everyone and their mother doesn't want steroids anymore. Some like wellness influencer must have posted somewhere on social media that corticosteroids are bad for you. So everyone and their mother, for some reason, wants to try PRP or prolotherapy, or NSAID injections, or hyaluronic acid injections for some reason. And I don't know why, but the evidence for all of these is really pretty weak. The PRP injections are almost never covered by insurance. And they have some evidence to show there's some efficacy, but really it's particularly in younger individuals who have mild arthritis, who are not obese. That's really the kind of the group, and mostly in the knee. There's not much evidence for other joints. So sometimes I'll do a PRP injection into a 40-year-old knee, but very, very rarely do I do this. It also costs a lot of money out of pocket, and patients can't afford that. Lastly, and something that kind of I've been using more frequently here is intra-articular ketorolac injections, right? So Toradol, we usually use this as an IM injection. We need more studies to really know how well this is, but patients who want to avoid steroids, patients who have GI upset with oral NSAIDs, doing a intra-articular ketorolac NSAID can be beneficial. It's off-label. It's not FDA approved, and we need more studies. But this is something which is sort of being used more and more clinically, which has pretty good benefit. So, okay, what do we think about when it comes to steroid injections, right? So really the pros here, you get some pretty rapid pain relief. It usually takes 2 or 3 days for the steroid to work, and often it can last, up 3 months is sort of the official answer. But I've had patients who've improved with pain up to 6 or even 9 months later. Now the key is I have them do physical therapy during those first 3 months, especially while the medication is working, and then it may minimize the wear and tear or inflammatory process later. But sometimes breaking that cycle of pain and inflammation can be really helpful. Really, patients who need sort of like short-term control, patients who are not candidates for surgery, and there is some evidence actually doing like some extended release corticosteroid formulations may provide longer lasting than the immediate release preparations, but really that's not very, very well understood. And for myself, triamcinolone is the one that I use the vast majority, maybe betamethasone, but triamcinolone is sort of the workhorse here. And then the cons, obviously, the effect is temporary. Often patients need repeated injections every 3 to 6 months for ongoing relief. There is a potential actually that you can actually accelerate the osteoarthritis progression. There's some evidence that there's some chondrotoxicity to the lidocaine or bupivacaine or whatever anesthetic you're using. And so the repeated injections can kind of progress the process of osteoarthritis. However, if patients already have arthritis and they're limited, then it is certainly that kind of cost benefit decision you have to think about. And then injections don't really alter the underlying disease process. There is very rare adverse events such as bleeding or infection, which is very, very rare, but it can happen. So I think it's important to think about these things while you're counseling your patients regarding the risks and benefits of steroid injections. Okay, so audience participation. Which steroid injection or which type of corticosteroid is the best for osteoarthritis? Make sure you guys are paying attention. Anyone fall asleep out there? No one? Nothing? IV and PO is coming to mind. That's okay. That's okay. It's actually a trick question. It doesn't matter. Any IV steroid will benefit. Again, betamethasone, triamcinolone are probably the workhorses, but any corticosteroid works. You talk to 10 different physicians, you're going to get 10 different cocktails. Some people like using, 40 milligrams of Kenalog and 4 milligrams of lidocaine 1%. Some like using bupivacaine. Some like using. Anyway, the point is there's no good evidence one works better than the other. So just whatever you like using and whatever you're trained on, just keep doing that because until new evidence comes along, it doesn't matter. So it's a trick question. I'm glad you're paying attention though, at least some of you. Okay, so again, thinking about sort of other kind of treatment options here for osteoarthritis. So a lot of patients ask about supplements, right? Glucosamine and chondroitin sulfate and other dietary supplements. Glucosamine and chondroitin sulfate does have some benefit if you take it orally on a regular basis. It can reduce pain, inflammation from osteoarthritis. It's kind of variable. There's 100 other things out there for joint health. There's no good evidence that they work. The best evidence is for glucosamine and chondroitin sulfate. Intra-articular hyaluronic acid injections and other biologics, as I mentioned before, PRP and stem cell injections and all this stuff. There's no evidence whatsoever that it works. Well, that's not true. It is no strong evidence whatsoever that it works. There is some anecdotal evidence. There's some very small, not great quality studies that show it may have benefit, but there's nothing out there. So I almost never. I sometimes will use hyaluronic acid injections if patients have stopped responding to steroids over time, or they're really worried about steroids. Sometimes, and I guess I should have mentioned this earlier, sometimes in patients with diabetes, especially if they have very, very brittle diabetes, steroid injection can cause their blood sugar to go up temporarily. Sometimes I'll use hyaluronic acid in those patients, but that's very, very rare. For most of the time, I just use steroid for those patients. And then obviously, lastly, and our last option here is surgical treatments, right? We can do a total joint replacement who failed conservative management. Obviously they have to have confirmed moderate to severe arthritis. And they need to have some moderate or severe pain and functional limitations. And really, this is all about shared decision making. What other comorbidities does the patient have? What are the risks of anesthesia and surgery? There's a lot of factors here. And patients, this is probably one of the biggest questions I get asked from patients who have severe arthritis is, do I need a knee replacement? Do I need a hip replacement? And I tell them, look, you need a joint replacement when you're miserable enough because a joint replacement doesn't fix things. It's not going to create a perfect joint, but it needs your pain has to and functional limitation has to be so severe that a joint replacement is an improvement. And there's no set answer. It all depends on the individual. I tell people once you're miserable and all the other treatments stop working, if you want to think about a knee replacement, that's reasonable. Some patients who want to go get a knee joint replacement earlier, some surgeons will discourage them from doing that because they wear out after 10 to 20 years, and we have to do another one if the patient's young enough. Some patients wait too long, and then if they're in their 80s or 90s, they may have too many other comorbidities to safely get surgery also. And so again, it's really individualized for each patient. This is where working closely with your surgical colleagues is really helpful to make sure we are kind of being patient-centered in our approach. But there's no one size fits all when it comes to total joint replacements. Okay, this really quick, I want to mention this because this is actually really pretty cool. Has anyone heard of geniculate nerve ablation? I'm going to guess no. um, oh, you have? Oh my gosh, look at that. Geniculate nerve ablation actually is a great emerging treatment for patients who are maybe they have severe pain, but they have too many comorbidities for a joint replacement. Maybe they don't want to have a joint replacement. So basically, this is a minimally invasive, effective, and a pretty safe option for refractory knee arthritis and pain. So basically, what they do is they go in there and they just literally radiofrequently ablate the nerves, the geniculate nerves that run to the knee and innervate the knee capsule and joint space itself. So there's moderate evidence really supporting its use for short-term pain and function. We don't really have long-term studies yet because it's a relatively new procedure, which is sort of just gaining in popularity. But it's really pretty cool. To think about, okay, we're just, we ablate nerves in the spine for chronic back pain all the time. Why can't we ablate nerves in the knee? And so this is something that's sort of emerging. It's not ready for sort of prime time yet, but something to kind of keep our eye on. I bet this will become more common in the coming years or decade or two. I bet, based on my suspicion. All right. Does it work for hips? That's a great question. I don't know, actually. I'm not sure there's really any evidence for that. I mean, in theory, yes. I think the hip is obviously a deeper joint, has probably more innervation, which may be interesting. But yeah, geniculate nerve ablation is really pretty interesting. So LA County's offering it. I see in the chat. Very cool. All right, moving along to back pain. Everyone's favorite diagnosis or favorite chief concern when a patient comes in. So again, 84% of adults at some point in their life have back pain. Right? I've had back pain before. I bet most of us on this call have had back pain at some point in our lives. And if you interview patients, 40%, nearly 40% of those have had back pain in the past 3 months. It's the leading cause of outpatient encounters when it comes to musculoskeletal pain and concerns. Again, focus history and exam is really the key here to identify red flags, right? So those red flags, which make you really worried, this is more than just sort of like mechanical or non-specific back pain. If they have saddle anesthesia, urinary retention or incontinence, they have an abnormal neuroexam and weakness or lower motor neuron signs on exam. If they have signs or symptoms of an infection, that makes you obviously very worried. If they have a history of IV drug use, if they have a history of cancer, or there's some kind of trauma, those red flags kind of pique your interest. But if patients don't have any of those red flags, the recommendation here is really not to do any kind of imaging in acute or subacute low back pain. This is the vast majority of these patients do not have any serious underlying condition, and the Choosing Wisely program strongly grade A recommendations do not image low back pain within the first 6 weeks unless those red flags are present, because all it does is it increases anxiety and further imaging tests, and we kind of go down the rabbit hole, which ultimately is going to probably cause more harm than cause patient benefits. So really, what do we do? What do we treat back pain with? What works? Really, heat, massage, acupuncture, spinal manipulation, plus or minus, all have kind of moderate to low quality evidence. NSAIDs or skeletal muscle relaxers can be considered, although we have to be careful in our elderly patients. PT and cognitive behavioral therapy, right? We know that the mind and the body are deeply connected. When people deal with back pain, it limits their ability to function, to move. They develop more anxiety, more depression. Hence, using SNRIs or TCAs such as duloxetine or amitriptyline can be helpful. Acupuncture actually has relatively moderate evidence to help with acute non-specific musculoskeletal back pain. Opioids are obviously, we want to limit them. They're not good for long-term use, maybe in the acute setting for very short, but highly discouraged for long-term use because of all the sequelae therein. And then here we are, epidural steroid injections, just like we talked about for the knee. Epidural steroid injections are not recommended except for short-term relief, particularly of radicular pain, and not within the first 3 months. This is usually has to be chronic before we think about doing epidural steroid injections or nerve ablations here. And then you can consider consider surgery only in those most refractive cases or those with progressive neurologic signs or symptoms. If we think there's cord compression, if we think there's specific nerve root impingement, where they're getting a lot of radicular symptoms, that's where you may want to think about getting more advanced imaging or getting your either your interventional anesthesia colleagues or surgical colleagues on board. But usually that's a longer term solution. So basically, the most likely diagnosis here is non-specific back pain. It's usually not dangerous. It's not a serious problem. It's often common. It's manageable. If you're a betting person, no red flags. 99+% of the time, this patient is going to get on better on their own, and really helping educate them and helping them understand that, look, okay, you have this acute, your quote back went out, you have the acute muscle spasms and inflammation. It's not going to get better right away. It may take a couple of weeks before you feel better, but steady, slow, consistent physical activity, core strengthening, heat, massage, topical muscle rubs, NSAIDs, those are really, really the mainstay here. I tell patients, you don't want to do nothing. You don't want to just lie on the couch when you're having an acute back pain, because often that just makes things worse. But if you do too much physical activity, that makes things worse either. And finding that balance point where you're kind of doing a little bit every day and doing a little bit more and a little bit more. I tell them, don't do anything for too long. Don't sit for too long. Don't stand for too long. Don't move for too long. Just kind of keep slowly moving all throughout the day, keeping that back warm, keeping that, sometimes using a heating pad throughout the day can help prevent a lot of those muscle spasms or reduce those muscle spasms overall. And so again, if we think about sort of the most likely things, non-specific mechanical low back pain, far and large is the most common condition we see in our offices. You can get a lumbar sprain, you can get some degenerative disc disease. Part of the reason we want to avoid imaging early is because we almost all find things on imaging, and then it kind of takes us down that rabbit hole. A lot of times, patients, if you have a herniated lumbar disc or you have radicular symptoms, that's really where you think getting advanced imaging or MRI can be helpful. But oftentimes, if we get even just back X-rays, we'll see some, foraminal stenosis, we'll see some degenerative disc disease. It often creates more anxiety, more worries, resulting in more visits and more workup, and we kind of go down that rabbit hole. Lumbar spinal stenosis, obviously, this is something we want to treat more specifically, although much less common. And then spondylolisthesis, spondylolysis, these are much less common, often in sort of a traumatic setting, but typically not something we see on a regular basis without any of those red flags. All right, so these are the things you can't miss, right? We obviously, we don't want to miss these diagnoses. So caudal equina syndrome, again, if they have those red flags of bowel or bladder incontinence, if they have radicular symptoms, if they have weakness or numbness or paresthesias in one leg, that's concerning. Ruptured AAA or a dissecting AAA, it can result in back pain, right? We all remember that. And so if you have that pain stabbing through to the back, you should always think about a AAA. It's one of the diagnoses you don't want to miss, especially for my ER colleagues out there. If you have malignancy, if they have an active malignancy or they have a primary, a form of malignancy, we always that should pique our interest a little bit. And then they have compression fractures. Again, this kind of goes back to my initial piece of osteoporosis. If they have a compression fracture, if they have point tenderness on their spine, then you should think about maybe compression fracture and osteoporosis. Right? Those are things we don't want to miss. So here, I know we went through a lot, but here are kind of the key takeaway points. Obviously, thinking about early identification, risk and assessment is really critical when it comes to preventing disability and fractures from osteoporosis or just limitations in function from arthritis. Non-pharmacologic interventions, exercise, education, weight management. This is absolutely foundational to managing osteoarthritis, to back pain, to osteoporosis. Like that should be the first thing we reach for. Pharmacologic and procedural therapies should be reserved for selective cases at escalating needs based on the individual and their clinical course. And then we obviously want to think about fractures, vertebral compression fractures, and advanced joint disease are really a huge driver of pain, of disability, of loss of independence, which we obviously don't want. And thinking about really engaging with our patients about how we can be very patient-centered in our approach. And then lastly, thinking about the prompt recognition of these conditions, what's the evidence-based treatment guidelines, and how can we improve their outcomes, treat them early to help reduce healthcare burden and also impact on the patient's quality of life. And so, all right, that was a lot of information. And now we'll open up to questions. I know I said there were a couple in the chat as we went. I kind of was keeping an eye on things. So I'll turn it over to you, Allison.
That was very nicely done, Dr. McDonald, and a lot of great information. You are kind of a genius. I already
I
knew that,
don't
but
know that's fun. I don't know about that.
I think I will remove the qualifier. There's no kind of there. You are a genius. That was amazing. Okay, so let's see. I'm not sure if you addressed these as well. Armando Gallegos, thank you for being so engaged, Armando. And did you get the answer to what does MT stand for under crystal arthropathy?
Yeah, first metatarsal joint. So the base of the great toe. Yeah.
Okay, great. Fatmayat said, do you usually measure vitamin D level first or supplement right away if patient is diagnosed with osteoporosis?
Great question. So for osteoporosis, I'm sorry if I didn't make this clear. I will often check a vitamin D, a calcium level. I'll check a creatinine also, because those all have implications for treatment. And so most people, I think, especially even here in Southern California, are vitamin D insufficient. I wouldn't say they're vitamin D deficient. So I will usually supplement them with 1 to 3,000 international units of vitamin D3 a day, typically. I sometimes will check the level just to make sure, especially if I'm starting them on a bisphosphonate. We definitely want to make sure their calcium and their vitamin D is replete if we're starting them on a bisphosphonate. So I will usually check those at the initial diagnosis and then just put them on supplementation. And then I don't check after that as long as they're on supplementation consistently. But that's a great question.
Okay, great. And then Armando, you may have addressed this, but it says arthritis is the joint space alone. Meniscal tear involves musculature.
Yeah, so I think that was answering the question about sort of the difference between
Yeah.
arthritis versus a meniscus tear, and it's like I said, it's sort of a spectrum. Often you can have a traumatic meniscal injury, which is going to result in arthritis, or you can have wear and tear over time, progression of arthritis, which results in chondrosis, thinning of the cartilage, and then degenerative meniscus injuries over time. So it's really kind of a spectrum the way that I think about it.
Okay, great. And then back when you were talking about the treatments for that and the pharmaceutical treatments and stuff, Ronnie asked, does this work for hips?
Yeah, I don't know actually. That's a great question about hips when it comes to, I mean, definitely, corticosteroid injections into hips. Hips are a little bit harder because it's a deeper joint. It's actually better to do either ultrasound or fluoro-guided intra-articular hip injections. So that's what I will do in my clinic, but I actually have ultrasound and ability to do that, whereas I know not everyone does. But I think the particular question there was the geniculate nerve ablation and ablating the nerves to the knee joint and the knee capsule, rather than just sort of treating the pain. And I don't know if they do that for hips or not. Something to think about.
Thank you.
Yeah, very cool. Thanks, Ronnie. Also, Armando posted something here that you may want to look at, Dr. McDonald, about UCLA Health offering this intervention for nerve ablation. Did you want to say anything about that,
Yeah, no,
Armando?
I
Here,
think it's
Doctor.
awesome. Please, Armando, if you
Yeah.
have any thoughts.
Yeah.
Yeah, no, thank you, Dr. McDonald, for the presentation. I really like the fact that there was a big overview of a lot of the common MSK problems we see in the clinic. I do have like a number of other questions, but I want to temper, because I want to be mindful of everybody's time. So I'll just narrow it to just one or two questions. I think the one question that I really wanted to know and get your thoughts on, because I'm a little bit younger, I'm coming a little bit late into the game, and so you guys have methods to kind of convince patients to do non-pharmacologic interventions before looking at topical, like NSAIDs. So how do you convince a patient to actually do exercise when they're complaining of knee pain? Like, how do you convince them? Because with vascular disease, you always want to convince patients with claudication to move through the pain. But I think it's a little harder to do that with MSK. But I love your thoughts on that.
Yeah, that is a great question. I think it's really about sort of engaging your patient and sort of meeting them where they are. A lot of patients are afraid to move because it hurts, which is a very normal reaction. But I will often encourage them, and I will sometimes say to them, "Look, this may get worse before it gets better." And just kind of giving them anticipatory guidance to say, "Okay, look, if we're going to start moving this joint, you may have more pain initially, and that's okay." Encouraging them that pain does not necessarily mean damage or further damage to the joint space. Um, Being their primary care doctor, having built a longitudinal trusting relationship with them is really key here. You can't always do that when you are just meeting the patient for the first time. But if you can if you can talk to your patient who's you're their primary doctor, that can be helpful. And then furthermore, helping patients to sort of understand the diagnosis. I will show them their x-rays. I will show them sometimes on ultrasound. I'll do a point of care ultrasound right there in the clinic and kind of show them the joint or show them the disease, and the pathology will help them to kind of understand that. I will often recommend, very light, very, very light, non-weight bearing, open chain exercises to start with. I'm a big fan of swimming and cycling for patients who have so much pain that they can't even walk, or think about doing something more vigorous, starting really slow. And then also, again, thinking about our SMART goals, right? You're gonna swim for 20 minutes, three times a week for 6 weeks, and then we're going to reassess and see how you're doing at that point. Being very kind of specific when it comes to our exercise prescription. That's a whole nother talk I have, by the way, about exercise prescriptions. But being very specific in that, and then also if they're having so much pain they can't even do the rehab, that's really where I talk about corticosteroid interarticular injections, topical things like that, to help bridge that gap while they start getting stronger, while they start moving that joint. And then that way, by the time the steroid kind of wears out in 3 to 6 months, the physical therapy has then sort of taken over, and we've built some new biomechanical patterns. We've offloaded different aspects of the joint. But it can be really hard, and there's no one size fits all approach. I hope that helps.
It does. Thank you.
Thanks, Armando. I'm not seeing any other questions in here. I know you do have a clinic to get to, Dr. McDonald. Do you want to kind of bring it to a close, or do you have time for one more? What do you want to do?
Yeah, I do have one of my first patient has checked in, but I'm happy to answer if there's one more question, or people can reach out to me, alex.mcdonald@kp.org. Send me an email. I'd be happy to connect offline or talk further. So
Okay, I think that's wonderful, and we appreciate you guys being so engaged too. So thank you, Dr. McDonald. That was so wonderfully informative and covered all the physiological issues, but as also some procedural issues for physicians. So thank you very much. Big round of applause, and we sure do appreciate you. And we will see you all next. Well, actually, we've got another one of these sessions in 2 weeks, November 18th, and this is on substance use disorder with Dr. David Siegler. So we will get this invitation out very shortly. But thank you all. So we'll talk to you, if not before our next session, then have a lovely Thanksgiving. And thank you all. Thank you, Dr. McDonald, again.
Thank you.
Okay, thanks. Bye, everyone.